Hello and welcome. My name is Tim Poe and I'm the Director of Telehealth with the UNC Cancer Network. Thank you so much for joining us today. A few things I want to go over and then we'll get started. If you're running into any trouble at all with the connection, you can email us at unccn@unc.edu. You may call or text us at 919-445-1000. We're going to use Poll Everywhere for some Q&A and to provide a poll to you in a few minutes. We'll talk more about that, but the information is there. And we hope you'll find us on the web at unccn.org. You'll find over 185 different videos online, as well as lots of information about upcoming events. We hope that you'll check us out on Facebook, check us out on Twitter, and on YouTube as well. All right. I mentioned that poll. Here's the question. The cancer is the leading cause of disease-related death among children and adolescents. So if you think this is true, you're going to mark A, and if you think it's false, you're going to mark B. And let me show you how to do this. So there are two different ways you can get to this Poll Everywhere poll. You can go to pollev.com/UNCCN. So if you wanted to use a computer or a web browser on a smartphone, you could get to us that way, and then you could go ahead and just mark A for true or B for false. Alternately, and for most folks, it's even simpler to just go ahead and text the letters UNCCN to the number 22333. You do that just one time. It'll say join, let you know that you've joined the Poll Everywhere session, and then you can mark, again, if you think cancer is the leading cause of disease-related death among children and adolescents, you'll say A for true. If you think B for false, then you'll mark B. And then we'll see those in real time in just a moment. So you're texting to the number 22333, the letters UNCCN, one time to join. Then you can answer. And then after that, towards the end of the presentation, we'll have some question and answer. And we hope throughout the presentation you'll be thinking about questions, jotting those down, and then we hope you'll have lots of questions for our presenter right at the end. All right. Today we're very fortunate to be joined by Andrew B. Smitherman. Dr. Andrew Smitherman is a Pediatric Hematology Oncology Fellow at UNC Hospitals in Chapel Hill. Dr. Smitherman received his medical degree from the Brody School of Medicine at East Carolina University. Currently, he is leading a study made possible through a generous grant from the St. Baldrick's Foundation. And with this study, Dr. Smitherman is studying how doctors can best care for pediatric cancer survivors by determining whether medical science can prevent or lessen the severity of return visits to the hospital. All right, Dr. Smitherman,
Great.
Welcome. We are so pleased to have you here today.
Thanks, Tim. It's a pleasure to be here.
Absolutely. Let's go ahead and take a look at this poll and see if anyone's had a chance to answer this. And while they are, let me ask you, what led you to on your particular career trajectory and with oncology in mind?
Thanks for asking that. So I started out my career as a high school teacher before going to medical school, and I've always had a love of working with adolescents, young adults, and children. And then when I went to medical school, I went on to residency in combined training in internal medicine and pediatrics.
Great.
And as I finished that training, I was thinking to myself, how can I best use this unique training in both internal medicine and pediatrics? And I discovered that taking care of childhood cancer survivors would be a great fit for using that training. And so that's what led me to explore the field of pediatric oncology, and why I've decided to dedicate my life to taking care of these patients and their families.
Well, they're very fortunate that you did, and we're fortunate to have you here today.
Thank you, sir.
Looks like we're trending with true here. We've got 100% saying true. So far, no falses at all. How are they doing?
Looks pretty good. I think that's a good response.
Okay.
That's exactly right.
Okay, terrific. And you'll find out a lot more about that. The presentation today, Caring for the Patient and Family Experiencing Pediatric Cancer or Adolescent Cancer. So with that, I'll go ahead and turn this over to you and the cursor as well.
Great. All right. Well, it's absolutely a privilege to be here this afternoon, and thank you all for joining us, for being a part of this discussion. Caring for children and adolescents with cancer is something that I feel very strongly about, and so much so that I've dedicated my life to taking care of these patients and researching ways to improve our care of these patients and their families. And so I hope that within the next hour or so, I'm able to share a little bit of that enthusiasm with you as well. The treatment of childhood cancer is one of the great success stories of 20th century medicine, but you're going to see that we still have a long way to go and there's a lot of work still to do in this field. So what are we going to talk about today? Here's the outline for my presentation. We'll start out by talking about some general concepts in childhood cancer epidemiology. Who are these patients? What cancers are they? And what's their survival from these cancers? We'll talk about two specific cancer types, leukemia and Wilms tumor, and use these as models to help us understand the treatment, the diagnosis and treatment of childhood cancers. And once we talk about the treatment, we want to think about, well, what are the side effects? What are the late effects that these patients are experiencing from their therapy? And then talk about the cancer fighting team. Who is important to be a part of this team to make sure that we are giving optimal care to these children and their families? And then if we have time, I want to talk about a new intervention that's on the horizon and I think has shown great potential as a treatment for some very difficult cancer types that have shown difficult to treat. So throughout this talk, I hope to stress some ways that pediatric cancers are really different from those in adults and let you know as we hit each of those points that I showed you on the outline that we can't treat children as just little adults, but we actually have to address their cancer and their needs in a very unique way. One of the ways that pediatric cancers are different from adult cancers is that they're relatively uncommon. This figure demonstrates the annual incidence of new diagnoses of cancer that's plotted by the age of the patient at the time of their diagnosis. And it demonstrates that the vast majority of cancers are diagnosed in patients who are 60 years old and older. If you look at that little section from 0 to 20 years of age, boy, it only represents about 1% of total cancers. And so this, when you think about cancer, often what comes to mind is prostate cancer, breast cancer, these very common cancers in the U.S. More than 250,000 women diagnosed with breast cancer each year, nearly 250,000 men with prostate cancer, lung and colon cancer are very common as well. And just to give you a sense of relatively where childhood cancer sits with that, well, we're way down at the bottom of the incidence by cancer type. Pediatric cancers only represent that 1% of all new diagnoses and about 15,000 new cancers a year. And so you may say, well, Andrew, why are you interested in dedicating your life to caring for this small percent of the population? And I'd say, well, there's two reasons that have really inspired me to care for these patients. One is that cancer is the leading cause of death among the disease-related death among children. Accidents certainly are the greatest cause of death in children, but cancer kills more children each year than the other disease-related causes of death combined. When you think of diabetes or asthma, infections, cancer will kill more children than all of those combined. And so that's one reason. Then another is when we treat these patients, we're looking to the future and thinking about what is the impact that it can have on these lives. And our hope is that by curing the cancer in these children, that we're able to provide them with years of longevity, decades of life afterward, and good quality of life after. And so that's really inspired me to be a part of childhood cancer care. So what are the common types of pediatric cancers? And I'll break it down into two general categories. One I would consider to be liquid tumors, those tumors that are in the blood and in the lymph system, like leukemias and lymphomas. And then the others are solid tumors. And the common types of solid tumors in children and adolescents are brain tumors, something called embryonal tumors, which are come from embryonic cells, primitive cells. Sarcomas of bone and muscle tissue are another common type of cancer. And then gonadal tumors in the ovaries and in the testes. These are the major categories that I think of when I think of childhood cancers. And this is another big difference with adult cancers, is the fact that we have to think about the child along a developmental continuum. These children from birth to 20 go through a range of maturity, and at different ages, these cancers have different, they're more common at different times of childhood. And so that's demonstrated here, where children ages 0 to 14, the most common cancer types are leukemia, brain tumors, and then in adolescence, it then becomes lymphoma, thyroid cancer, and brain tumors are still a big issue. And so we have to think about, when we're diagnosing and treating these patients, about the specific developmental stage of these patients. And that helps us provide better care. And the care has really improved significantly through time. This figure demonstrates survival outcomes from all pediatric cancers from the 1950s through 2000s. And this figure demonstrates that survival has improved dramatically over time. And this is, like I alluded to at the opening of the session, the treatment of childhood cancer is really one of the great success stories of 20th century medicine. But there's still a lot of work that needs to be done, and this figure breaks down survival by specific cancer type in pediatric and adolescent cancers. I'm going to put in a red arrow here, and that shows us that average of 80% of cancer survivors. So cancers that were uniformly fatal back in the 40s and 50s, now 8 out of 10 patients will go on to be long-term survivors. And so that's the average survival rate for childhood cancers now. Many of these cancer types fall far below that average survival rate. You can see particularly CNS cancers, central nervous system cancers, brain tumors, and those sarcomas still have a lot of work to do in increasing our survival rates from these cancer types. And you really can't talk about the improvements in the treatment of childhood cancers without thinking about some of the giants in the field, like Dr. Sidney Farber, who's considered the father of chemotherapy. So Dr. Farber was a pathologist at Boston Children's Hospital, and in the 40s, he began to think about, are there other ways that we can treat patients using perhaps some sort of chemical, some chemotherapy, or some drug? Up until that point, cancers were treated with either surgery or radiation. Oftentimes, many cancer types can't be resected with surgery. Radiation has very significant side effects. And so Dr. Farber was trying to explore other avenues of treating childhood cancers and thought about using initially an agent that blocks folic acid metabolism, a drug called aminopterin. And the first patient population in which he tried this drug was the children with acute lymphoblastic leukemia. So these children at the time were not treated. They were sent home, unfortunately, to die because there were no effective therapies in the 40s for leukemia. And Dr. Farber used aminopterin to actually induce what's called remission in these children with what had up until that point been an untreatable disease. And so, unfortunately, the remission didn't last permanently. These children would often achieve remission for a month or two, and then the cancer, unfortunately, would return and the children would succumb. But Dr. Farber gave us a glimpse into just how powerful the use of chemotherapy agents could be in treating childhood cancers. He also did groundbreaking work in the treatment of Wilms tumor, where he combined a drug called actinomycin D with radiation and showed that multimodal therapy can be successful as well. And building off of the work that was done by Dr. Farber at Boston Children's, researchers began to realize that, hey, we need to pool our resources and we need to work together in cooperative groups to try to figure out what's the best way that we can treat these young people with cancer. And so out of that was born this new era of using clinical trials to improve cancer therapy in children. One of the first cooperative groups that existed was the Acute Leukemia Chemotherapy Cooperative Study Group that was founded in 1955 and included only 9 hospitals. And their first trial enrolled a small number of 168 children. And that trial looked at the comparison of a drug called 6-MP, 6-mercaptopurine, versus 6-MP with the addition of a second agent called azacitidine. And the results demonstrated that really the addition of azacitidine doesn't make a difference, doesn't really help or provide extra benefit. And interestingly enough, 6-MP is still one of our go-to drugs for the treatment of acute leukemia. And now you can see just how far we've come. The Children's Oncology Group, which grew out of, this is the Cooperative Trials group that grew out of those early cooperative groups, now includes over 230 institutions in North America, Europe, and also in the Pacific. And more than 90% of children who are diagnosed with cancer within one of these countries will be treated at a COG-affiliated site. And in 2007, there were over 70,000 children being followed in COG trials. And so it's really this use of cooperative clinical trials that has helped us understand how to better treat these children and has really contributed to the improved survival outcomes we've seen. So now I've talked a little bit about the background, the epidemiology of childhood cancers and some of the early efforts of treatment. And I want to turn our attention to a couple of specific cancer types and use these cancer types as models for how we diagnose and treat cancers. And I've chosen one of those liquid tumors, one of those solid tumors, to give you a sense of some of the differences between them. And so this first case is a very common case for us in pediatric oncology. It begins with a 3-year-old young lady who's brought into the emergency department. She's had fever for several days and leg pain. And the leg pain is so much that this normally rambunctious little girl is limping. Oftentimes she won't even want to bear weight on that leg. She's been seen several times in the last couple of weeks with this fever and this pain, and she was diagnosed with a viral illness, thinking that maybe the leg pain was coming from some inflammation associated with the illness. And then mom began to notice that, boy, she's bruising a lot as well, and these bruises are all over the body, not the typical toddler bruises on her legs. And she's also developed these red dots. And then sort of the straw that broke the camel's back was at preschool today, she developed a very significant nosebleed, very hard to stop, and so mom and dad decided to take her to the emergency department. And there in the emergency department, the doctors began their evaluation, drew some blood, and this is what they saw under the microscope. This is what's called a peripheral smear of blood drawn from a vein, and you can see both white blood cells, which are the purple cells, the larger cells, and red blood cells in the background. And basically, there are too many white blood cells here. And so this is acute leukemia, where the white blood cells are starting to divide out of control, are crowding out the bone marrow, making it difficult for those other blood cells to grow in the marrow where they should be. Acute leukemia is the most common childhood cancer. About 30% of all cancers diagnosed in that age group from 0 to 14 are acute leukemia. And it can be broken down into 2 categories, lymphoblastic and myeloblastic. We call them ALL and AML. And as you look at the figure that's below the peripheral blood smear, that shows the maturation process of the blood cell from a very primitive blood stem cell that early on divides into myeloid and lymphoid precursors that go on to make the myeloblasts and the lymphoblasts. And those are the cells that become dysregulated, grow out of control, and that is what leukemia is. Lymphoblasts should go on and mature and become B cells and T cells that help fight off infection. Myeloblasts should go on to become neutrophils, eosinophils and basophils, part of the innate immune system. However, they get stuck in that blast phase and grow out of control. ALL is much more common than AML, unfortunately so, because AML really does carry a poorer prognosis. Childhood leukemia, ALL specifically, is much more common in that 2 to 5-year-old range, and that's demonstrated by the figure here, where there's a large spike in that 2 to 5-year-old range. And what's interesting is it seems to be much more common among Hispanics and whites as compared to blacks. And we really haven't figured out exactly why that is the case. You compare those rates to AML, that's the brown line at the bottom, and there's a little bit of a bump early on before that first year or in that first year of life, and then it trends down but then increases slowly. And over time, AML will overtake ALL and become more common among adults. But in children, it's ALL that's much more common. You may ask, what are the factors that can predict or what is it that has caused this cancer to arise? And I get that question a lot from parents. And really, we just don't know. For the vast majority of these cases, there's no associated environmental or genetic factor that has caused the rise of the leukemia. Although we've tried to figure out what could possibly be a predictor of this. In rare cases, some genetic conditions like Down syndrome, trisomy 21, are associated with that increased risk of both ALL and AML. But for the vast majority of cases, there really is no precipitating factor. So how do these children present? Well, they often come in as just like the case described, with fever, with bone pain. Often a physician will feel an enlarged spleen or liver and lymph nodes. And these patients will have difficulty with bruising and bleeding, and that's just because the normal blood cells, the platelets that should help the body stop bleeding, are sort of crowded out by these rapidly growing leukemia cells in the bone marrow. With cancer, you think about something called staging often, and that staging can help you with prognosis. Staging is much more of an helpful concept when you're thinking about a solid tumor. With something like leukemia, really you can't stage it because when you're thinking about the location of the tumor and how far it's spread, well, blood cells travel all around the body, and so staging really isn't helpful when you're thinking about prognosis in leukemia. So we use a risk stratification, and over time and with experience, we've come to understand that very young patients and those who are older than 10 years, patients who present with a high white blood cell count of greater than 50,000, those with certain mutations in their cancer cells or who don't respond to the typical initial therapy are all at higher risk and need some adjustment in their therapy to make sure that they have their best chance of survival. So how do we diagnose it? Well, it's done by a procedure called a bone marrow biopsy. And this figure demonstrates a patient lying on the side and often will access the back of the hip, go into the center of that hip bone into the marrow space, which is the factory of blood cells, take off a sample, and then look and see exactly how much of that marrow is affected by the cancer cells. ALL treatment is intense. It is a long, grueling process for the patients and for their families. And I think one of the key concepts that I want you to take away from the treatment of ALL is that you have to use multiple drugs and multiple routes to be successful. This is a lesson we learned way back with Dr. Farber, where you give one single drug and the cancer will certainly find ways around that treatment and come back. And so we've learned that we've got to attack the cancer cells in many different ways with different avenues of treatment and in different routes. We often use intravenous and oral, and even something that's called intrathecal, which is where we take a lumbar puncture needle, put it into that space right around the spinal cord, and give the chemotherapy agents into that spinal fluid. And that's because even though only 5% of children will present with cancer, leukemia in their spinal fluid, more than 80% will have recurrence in that spinal fluid if we don't do some sort of preventative therapy. And initially that preventative therapy was radiation to the brain and to the spinal cord. And we learned over time that that has severe side effects with mentation or cognition, and can even affect IQ. And so that led researchers to try to figure out other ways that we can prevent the spread of the cancer there, and that's using these chemotherapeutic agents that often wouldn't get across the blood-brain barrier by putting them directly into that spinal fluid. So on the lower half of the slide, this describes, in general terms, the phases of treatment for acute leukemia, and it's really in 4 phases. And a big takeaway is that the first 6 months are very intensive. We start with the first month, which is induction therapy. This is a time when we want to try to induce what's called remission, where we don't see any of the cancer cells under the microscope or with any of the tests that we have to more specifically look for evidence of cancer. And then we move on to a phase called consolidation. And that's where once we wipe out all the cancer cells, we just want to give it another pound with some different agents that are going to change it up a little bit and specifically target prevention of central nervous system disease. And then we'll move on to delayed intensification, where we change up the drugs a little bit again, trying to prevent resistance and just knock out any remaining evidence of that cancer from being there, even little amounts that we may not be able to detect. And then we move on into a maintenance phase where we're preventing the cancer from coming back. And that's a prolonged phase. What's really important about this time is this is when we want these children and these young adults to really get back into their typical routines. We want them back in school, want them getting a sense of normalcy to their lives. And so that maintenance therapy is mostly done at home. It's oral therapy primarily. It's once a month in clinic. And really, we hope to reestablish that sense of normalcy. When I am talking with a family early on about a new cancer diagnosis, specifically for ALL, inevitably the question comes up, so will my child lose their hair? And my response is, I don't know. Probably many of these drugs can cause hair loss, but there are many other side effects that we have to talk about as well. And really, these drugs are not specific to attacking the cancer cells. They do affect rapidly dividing cells throughout the body, and that's why we see sort of the spectrum of side effects that are associated with ALL treatment. The rapidly dividing hair follicles can lead, from the chemotherapy affecting those, can lead to hair loss. The rapidly dividing cells in the gastrointestinal tract often results in nausea, vomiting, loss of appetite, and mouth sores. And then these drugs particularly affect nerves as well and can cause numbness and clumsiness in these patients and nerve pain. And we really have to lean on our physical therapy colleagues to help us take care of these patients and maintain good function throughout this. So those are common side effects. There are also many severe and life-threatening side effects that we have to consider. One in particular for leukemia is something called tumor lysis syndrome, because these cancer cells are all over the body, circulating in the bloodstream. As we treat them with the chemotherapy agents, they often die, will break apart, releasing their toxins into the bloodstream that can overwhelm the kidneys and can cause dysfunction of the heart and the kidneys. And so we have to make sure that the patients have optimal supportive care during that early therapy period to prevent tumor lysis syndrome. Infection is another big side effect of the treatment, because all of these chemotherapy agents are immunosuppressive. And so these children are at high risk of developing bacterial and fungal infections, viral infections, and we have to make sure that we are preventing those. And it's really advances in the prevention of infections that have also added to our improvements in survival. Because we are dealing with cancers in the bloodstream, the other blood cells are often affected, as well as we affect the bone marrow with these chemotherapy agents and decrease the production of the platelets and the red blood cells. And so these patients can have bleeding, they can have blood clots that we have to deal with, and often we have to support these patients with transfusions of red blood cells and platelets. And then I wanted to particularly point out infertility as being a severe side effect as well. And this is something that, while it may not manifest its effects later on in life, it's something that we have to think about right up front as we're describing the treatment regimen to these patients and their families. And often at that point in time, we need to think about what are ways that we can preserve fertility as best as possible. And so with these improvements in survival have come, or with the improvements in treatment have come this improved survival with acute lymphoblastic leukemia. This figure demonstrates the improvements in survival with each subsequent era of treatment. And up until the 1996 to 2000 range there in red, you see that children now experience somewhere around 85 to 90% survival with a diagnosis of ALL. Just phenomenal improvements over time. And so I hope that gives you a sense of diagnosis and treatment of blood cancer, leukemia, acute lymphoblastic leukemia. Now we're going to turn our attention to one of the solid tumors. And so we'll start out with a case here as well. And this is a 2-year-old young man who was brought to his primary care physician by his mom. And mom feels like over the last week, he just has a lump in his belly. And when I give him a bath and I'm bathing his belly, it just feels like there's something protruding. And sort of when I press on it, it seems to make him irritable. It seems to be uncomfortable for him. And this is a very common story for the presentation of something called Wilms tumor, which is the most common kidney tumor in children. It's often diagnosed in children who are younger than 5 years of age, as opposed to leukemia, acute lymphoblastic leukemia. It's much more common among African Americans, and it can be associated with certain genetic conditions like Beckwith-Wiedemann or Dennis-Strash. And so this is a picture of a Wilms tumor there on the right, occupying a great portion of that kidney. So how do these children present? Just like in the case, often with painless abdominal swelling. Sometimes there can be pain associated. Maybe the child is noted to have some high blood pressure when they're seen by an evaluation of a medical provider. Sometimes blood is seen in the urine, and some will actually present with rapidly growing abdominal distension because these tumors have the tendency to bleed within them and can grow quickly. So I haven't mentioned much about screening yet, and this is another big difference in pediatric cancers versus adult cancers. With adult cancers, you hear so much about, well, have you gotten your colonoscopy? Have you gotten your PSA test or your mammogram? And screening has really made big improvements in survival outcomes in adults. But screening is not something that we use very commonly in children. Now, if there is a certain subset of the population that is at extremely high risk of developing a cancer, such as with Beckwith-Wiedemann and the risk for developing Wilms tumor, screening will be employed. And so these children, if a child is diagnosed with Beckwith-Wiedemann, they'll undergo ultrasonography of their bellies every 3 months or so, up until about the age of 7, to look for the development of a kidney tumor, of a Wilms tumor. And so this is what a Wilms tumor could look like on a CT scan, a CAT scan. We're looking directly at the patient, and you see this large mass that's displacing much of the right kidney there. There's just a little bit of the right kidney that's sort of a halo around that tumor mass. And so often our diagnosis comes directly from imaging and seeing that this tumor is arising from the kidney tissue. Biopsy plays less of a role in Wilms tumor. Biopsy is something where you take maybe a needle or go in and surgically remove a little piece of the cancer so that we can look at it under the microscope and get a sense of exactly definitively what is this tumor that's growing. Well, the risk with Wilms tumor by sticking a needle into it is that you can cause rupture and leakage and can actually spread the tumor cells around the abdomen. And so it's preferred that a biopsy not be done for these patients, and often we will let the definitive surgery, the excision of the full tumor, be our moment of biopsy. And so unlike leukemia, staging in Wilms tumor is very important. And staging is basically a way that we can get a sense for how widespread the cancer is. And that gives us prognostic value or information. So of all the stages in which patients with Wilms tumor present, stage 1 is the most common. And that's a tumor that's confined to the kidney itself. It doesn't get through the lining of the kidney, the capsule, and can be fully resected. A stage 2 cancer may be slightly extended beyond the renal capsule, but still can be fully resected. A stage 3 cancer would be one where the cancer extends beyond the kidney, maybe into some local tissues there, and the surgeon is not able to fully resect that tumor, leaving a little bit behind. And this would include also if a preoperative biopsy is performed with that risk of spreading the tumor around. Those would be considered a stage 3 tumor cancer. Stage 4 is when the cancer extends beyond the region of the kidney, goes distantly to somewhere else like the lungs or to the liver. And then stage 5 is a fairly uncommon presentation where both kidneys are affected at diagnosis. So how do we treat Wilms tumor? Well, it really depends on which side of the Atlantic you're on. We'll see that not all pediatric oncologists get to good outcomes the same way. If you are diagnosed with a Wilms tumor in North America, your tumor would be excised first. It would be resected by a surgeon first. And the reason for that is we want to get the tumor out, confirm that it truly is a Wilms tumor by looking at it under the microscope, and have the best chance at exactly what that tumor looks like under the microscope before we expose it to chemotherapy that can change its appearance. If you're in Europe, there you'll get chemotherapy first. And the thought is that by giving chemotherapy up front before surgery, we're able to shrink the tumor down, make it safer to remove that tumor, so hopefully you'll have less spillage at the time of surgery, and hopefully prevent the need for more intensified therapy like radiation therapy to the belly if there were spillage. So by giving chemotherapy up front in Europe, you may wonder, well, what is the risk of giving chemotherapy to a patient that truly doesn't have a cancer? And that is a concern, but typically the imaging findings are so distinct for Wilms tumor that rarely happens. The Europeans will report maybe 1 to 2% of patients will have a Wilms tumor, or will have a benign condition that receives unnecessary chemotherapy. So pretty low percentage. And they feel strongly that by giving the chemotherapy up front, that really helps improve the outcomes from surgery, being able to shrink these tumors down and effectively remove them. Well, in the U.S., the treatment is really multimodal, and in Europe as well. We use surgery, we use chemotherapy and radiation therapy. It's just at different time points that all of these methods are used. Typically for a stage 1 or stage 2 tumor, it's going to be cut the tumor out, and then we'll add a couple of chemotherapy agents to help make sure that we get rid of any of the cancer cells that are left behind. If a patient's really young, if the tumor is really small, resection alone may be enough. If the cancer looks really aggressive under the microscope, well, we may have to add additional chemotherapy agents to make sure that we have a good outcome. Stage 3 tumors often need radiation as well, because there's that concern that there has been residual tumor left behind or spillage in the abdominal cavity. And then certainly that's the case as well for stage 4. We'll use pretty intensive chemotherapy along with radiation to the sites of metastases. The adverse effects in Wilms tumor are very similar to those with the treatment of ALL. The chemotherapy agents are very similar, so you would see many of the same things like hair loss, numbness, weakness, clumsiness, nerve pain, nausea, vomiting. Some of the specific agents used to treat Wilms tumor can also cause liver toxicity. And like in ALL, one of the main severe side effects would be infection because these chemotherapy agents, once again, are very immunosuppressive. Because you often have to take out an entire kidney that's affected by a Wilms tumor, you have to think about preserving renal function. And so renal failure can be an issue in these patients, and we have to make sure that we counsel the families about preventing accidents to that remaining kidney. Bowel obstruction because of surgery in the abdominal cavity. You can have scar tissue after the surgery that can lead to bowel obstruction, and bleeding's a concern as well. And so this figure demonstrates the improvement with Wilms tumor treatment over time. And I like this figure because it adds in what was the improvement with the various modalities as they were added to the treatment regimen. So beginning in the early 1900s with surgery, saw a significant improvement into the 20s, and then in the 30s, radiation therapy was added to improve therapy. Chemotherapy added in the 40s and 50s, and after which we saw a dramatic increase in survival into the 60s and 70s. And then that line represents when cooperative groups started working together, doing large clinical trials. And you can see that that has really boosted survival even to that next phase of above 90% of all children diagnosed with Wilms tumor will be long-term survivors. It's a great outcome. So we've talked a little bit about the epidemiology of these cancers, who gets them, what's the survival rates. We've talked about a couple of different specific cancer types to get a sense of what's the diagnosis and treatment like for these cancers. And now we've talked about therapy and we've talked about short-term side effects. I want to share a little bit about something that's near and dear to me and something that I've decided to dedicate my life to, and that's how can we prevent the long-term side effects of these treatments? Because we really want a patient's quality of life to be fantastic after this treatment. Unfortunately, 2/3 of childhood cancer survivors will develop a chronic side effect due to their previous treatment. 1/3 of those will be severe or life-threatening. And so we've got a lot of work to do here. I think this is an area that's ripe for research, trying to tweak our regimens so that we still enjoy those great survival outcomes, but are able to prevent the long-term side effects. This figure demonstrates that long-term side effects from cancer treatment can really affect any organ system in the child and the young adult. From as we mentioned, with radiation therapy to the brain, where you can have cognitive defects, effects on IQ, and they can also affect the hormonal axis, the pituitary and growth hormonal axis, causing growth arrest. That children who have had radiation therapy to the brain have also been shown to be at increased risk of obesity later in life. There are also significant side effects to the heart. Many of these chemotherapy agents are cardiotoxic, and so we have to monitor our total dose of these, and the lungs can be affected as well. And then another one that I think is very important, and is actually, out of all of these, the greatest long-term side effect, the greatest killer of any long-term side effect, are unfortunately secondary cancers. So children who are exposed to radiation therapy and exposed to chemotherapy are at increased risk of developing other cancers, not just a recurrence of their first cancer, but a completely new cancer later on in life, such that by 25 years off therapy, 5% of childhood cancer survivors will have developed a secondary cancer. And so there's lots that we need to do in figuring out ways to minimize that risk. The Children's Oncology Group, the cooperative group that helps with conducting the clinical trials in pediatric cancers, has responded to this by creating these long-term follow-up guidelines for survivors. And this is a 250-page document that gives providers, anyone who sees childhood cancer survivors, some guidance as to what are the types of screening that these individuals need and how can we provide optimal follow-up care for them. And I'll just give you a sense. This is going to be an overwhelming slide because there's such little text here, but this is just one page out of that 250-page document, and it describes one particular drug category called anthracyclines, which have a particular cardiac toxicity. And so this page out of the long-term guidelines will tell you, well, which are the patients that are at higher risk? Well, those that had radiation therapy to the chest as well as anthracyclines, and those who were a certain age when they got the anthracycline, those are the ones who are going to be at higher risk, and so we need to watch them a little bit more closely. So then what do we need to do as far as our periodic evaluations? Well, we need to ask these questions on our history. We need to ask about shortness of breath and chest pain. We need to do certain physical maneuvers, make sure we're listening to their heart and looking for swelling, listening for fluid in the lungs, and we need to do screening as well, using echocardiograms, looking at the function of the heart and doing EKGs to look at the electrical activity of the heart. And so these guidelines have been a very big help in helping those who provide survivorship care, the most up-to-date screening guidelines. Unfortunately, many providers don't know that these exist or don't know how to access them, and so there's a lot of work that we need to do to make sure that anyone who provides survivorship care is aware that these guidelines are available. I've spent a lot of time so far talking about long-term side effects that are mostly physical, but I can't stress enough that psychosocial long-term side effects are also a very significant source of morbidity in this patient population. These, especially in pre-adolescent, adolescents, or young adults, if they're that age when they're being treated, they are particularly at risk of these long-term side effects. When you think about it, these are individuals who, and rightfully so, according to their developmental stage, will have a sense of invincibility. And so by coming face-to-face with a cancer diagnosis, they see this vulnerability within them and increased uncertainty and that fear of recurrence always hanging over their heads. And that can lead to this cancer-related distress, which then can go on and lead to psychiatric illness in these survivors. And I think that this picture is perfect because many of them will come to clinic and they'll say, "I'm doing great, doc. I'm feeling well. The cancer's behind me." But really underneath that water, they are just treading furiously and dealing with a lot of psychosocial distress. And so I think it's important for us all to realize that we need to be engaging the survivors, asking about these concerns and making sure that their life after cancer, they're adjusting to the life after cancer well, and that we support them in that. As these patients begin to think about how am I going to how's my life going to be different after this cancer diagnosis? I had certain goals and I had a very clear vision for where my life was heading before cancer. Well, that's often turned up on its head after a cancer diagnosis, and we need to support survivors as they deal with figuring that out. And I think a particular population that's at high risk of those psychosocial effects are the population, the adolescent and young adults. That's the AYAs. These are the late teens, early 20s, even into the 30s, who were really trying to. They had just at that point where they were figuring out where their life was heading, what their goals and hopes were for their life, and then cancer just comes in and, like I said, sort of just topples that and turns them on their heads. Often these individuals are dealing with body image problems because of maybe scars from surgery or from treatment. Often they had to put their career or their education on hold and they're trying to get back to some sense of normalcy. And financial issues are a big problem as well, as you have to postpone or put off your career in order to undergo this intensive treatment. So I'm going to get on my soapbox here just a little bit and talk about why I think it's so important that we support access to good health care for this patient population and access to insurance coverage. The Affordable Care Act has done great work to help with making sure that these patients are not restricted from being able to enroll within healthcare policies by not limiting patients who have pre-existing conditions. And now these survivors can remain on their parents' insurance policy up until the age of 26. And so I think that's done a lot to help make sure that these survivors have access to the care that they need. It's been reported that as many as 50% of all families that have been affected by a childhood cancer face a risk of bankruptcy. And it should never be that a bankruptcy lawyer should be a part of the cancer care team, in my opinion. So this leads to something that I think is really important for this population, and that's the survival gap among adolescents and young adults. And this is a figure that demonstrates the improvements in survival from the 1990s through the 2000s. And most of the bars are going in the right way. There's been improvement in survival in most age groups. However, if you look in the middle, there's this chasm in the late teens, 20s, 30s, where survival outcomes aren't as good as they are in the younger and the older populations. And in fact, some even in their 20s and 30s are experiencing poorer outcomes than they would have experienced back in the 90s. And we really need to address this, and this has led a lot of folks to consider what are the causes of this. Could it be because these patients may typically not be the ones you would think of as developing cancer, so their diagnosis is delayed? Maybe they don't have access to clinical trials to enroll on to get that cutting-edge therapy. Perhaps it's these psychosocial barriers that are preventing them from getting the care that they need. Probably it's a mix of all of them, but there's a lot of work that needs to be done here in making sure that adolescents and young adults enjoy the same survival improvements in survival as the other age groups. So that's a little bit about the long-term side effects, both the physical and the emotional, psychosocial side effects of the financial toxicity of cancer treatment. And now I just wanted to turn and talk about how the team that takes care of the child and the adolescent with cancer and their family, how they're very unique and very different from the team that may take care of an adult with cancer. And so here we have this adorable young patient in the middle with chemo duck, which is a stuffed duck that helps us teach about how chemotherapy is given. And this is our patient. And really, we pediatric oncologists would like to think, well, of course, we're the most important. We're the ones who diagnose the patient. We're the ones who come up with the treatment plan. Certainly, our surgical colleagues help us with doing the biopsy and removing a tumor. And our radiation therapy colleagues, okay, so we're probably the big three that are really important in caring for this patient. But the more that I am a part of this field, the more I realize that it really does take a village. And for instance, the nurses who are there at the bedside, counseling, interpreting doctor speak, and providing support, they're so very important. Psychiatrists, psychologists, counselors, helping with those psychosocial side effects of cancer and its treatment. Pharmacists who help us make sure that we get the right dosing and look for the interactions of particular therapies. Social workers who help make sure that these patients are able to get to clinic, to get to the hospital, to receive the therapy that they need. Physical therapists and child life therapists to help make this experience much more manageable for the patient and their families. And then the researchers who are trying to figure out ways to improve our therapies all play into this village that take care of childhood cancer patients. So this is a picture of some of the nurses from our UNC pediatric oncology floor here at the hospital, and they're with some of the UNC football players. Many of the athletes here at UNC contribute so much great time to coming and spending time with our patients, and we really do appreciate it. But the nurses play such a vital role. Like I said, they are on the ground at the bedside, providing that day-to-day care, they're the last stop before chemotherapy is administered to this patient. They hang the chemotherapy, so they're doing that last safety check. They play a vital role in making sure that the drug is appropriate. They are making sure that the patients and the families understand the treatment and can help with mitigating the side effects. and they are counselors and they are therapists in their own right at the bedside. Some other specific support folks who are part of our team here at UNC are child life specialists as well. They play a role in helping prepare children for procedures and can help teach them relaxation skills and can really provide a lot of support for especially young children to make sure that we medical providers can do the work that we need to do, minimizing the stress and impact on these young patients. They lead support groups and retreats and can help volunteer coordination of many of the young people from the campus here at UNC who come and volunteer and play a big role in supporting these children as well. And then school teachers. So this is a big difference from, I think, adults. You may not think of school teachers as being a critical part of the cancer patient treatment team, but they absolutely are, in making sure that we try to move forward with that expectation that school and the hospital, it's an implicit statement of hope that we are going to help you, we hope, achieve a remission and a cure, and life needs to move on, and school is part of that. And so the teachers work with these patients at unusual places. Their classroom is at the bedside. They work closely with families and trying to help arrange homeschooling for patients who may not be ready to get back to school quite yet, and work with many different school districts across the state and have to be familiar with a broad range of curricula as well. And so I hope that gives you a sense of how the treatment team is a little bit different of what it would be for a pediatric cancer survivor or cancer patient versus an adult. And lastly, I wanted to spend just a moment talking about a really exciting new therapy that's on the horizon. And this is something called chimeric T-cell therapy, or CAR-T therapy. And this is a treatment where we're hoping to use the patient's own immune system to fight difficult to treat cancers. We basically take off some of the patient's T cells, some of their white blood cells that fight infection. We genetically modify those cells so that they express a new receptor that more effectively, more efficiently recognizes the cancer cells in the body. Grow those genetically modified T cells in culture and then give them back to the patient so that they are able to go throughout the body, find the cancer cells, attack those cancer cells, and hopefully help us achieve a remission. So this is a therapy that has shown great promise, especially for some difficult to treat cancers, and it's a therapy that is coming to UNC. We're very excited that we will hopefully have this available for children in the near future. So with that, I just would like to summarize a few of the main points from the talk today. I hope that you've gotten a sense that these cancers are relatively rare, but still they're the #1 disease-related killer of children, that survival has improved significantly thanks to clinical trials, and that this improved survival has come at a cost, and we've got lots of work to do to figure out how we can limit these long-term side effects in patients. And that it's not just side effects to the physical patient, but also to the emotional and the mental patient, that there's great psychological and cancer-related distress that's associated with this treatment, and that really caring for these patients requires a multidisciplinary team, really does require a village. Lots of opportunities to be a part of the care for these patients and their families. So with that, I'd like to say thank you so much for your attention. Thanks for tuning in, and I'm happy to answer any questions.
All right. Thank you so much.
Yes,
this has been outstanding. I hope that you do have questions, and I hope that you'll get those to us. So a reminder that we have Poll Everywhere up here. If you did not join at the beginning, go ahead and take just a moment to do that. You just can text the letters UNCCN to the number 22333. Once you joined, then if you did the earlier poll, you're all set, and then you can go ahead and start texting your questions now. So you can also go to pollev.com/UNCCN, send us your questions there as well, or you could even just go ahead and email them to unccn@unc.edu, and our team will go ahead and forward those on. So with that in mind, I know I had a couple, but but I don't want to monopolize the questions, so I hope our audience will submit questions. You mentioned the psychosocial factors, and how do you go about restoring you? And it's not necessarily beneficial to have a teenager feel completely invulnerable, as we know. That can be an extreme as well. But I can imagine that losing that sense of that and having something so dramatic happen. What are some of the things that might be done to help restore some of that sense of, if not of invulnerability, of at least some normalcy in terms of looking forward?
That's a great question, Tim. And I think a big part of that can be involving other survivors who have gone through that process in the past with support groups. Yeah. So a young adult, a teen can identify with somebody who has gone through that experience and has really established a sense of normalcy in their lives. And so I think connecting those patients is also is always a great way of doing that.
No, that makes perfect sense. And I've seen some other examples of bringing together communities of peers and even utilizing social networking and other factors as a part of that. Let's see. Looking at that 80% survival rate, but obviously lower you mentioned in some areas. You mentioned the chimeric T-cell therapy. What are some of the other things that we might look forward to in the future that may help bring some of those lower percentages up and give move our overall 80% into the 90% range?
Right. It's a great question as well. And I think looking at more targeted therapies that are able to attack the cancer cells more specifically, as opposed to globally, like many of our chemotherapy agents do, and really tapping into the immune system, not only with these modified T cells, but thinking of other ways that we can sort of rev up the immune system to find these cancer cells and to fight them specifically. There's a lot of great work in immunotherapy and what's called precision medicine on the adult side. We're hoping that in time will translate to the ped side as well.
Okay. So that work primarily is in the adult area right now and hasn't translated to pediatrics.
Beginning to.
Okay. What about in terms of side effects? And I know you talked about that, but are there particular areas where we're seeing work that's either achieving or we expect to achieve reductions in terms of some of these side effects?
Yeah, absolutely. With experience, we've noticed that certain cancers, like for instance Hodgkin's disease, which is very common in adolescents, young adults, we noticed that, or with experience, we saw that young women who were exposed to radiation therapy were at really high risk of developing breast cancer later on. Risks as high as those women who have a BRCA1, the breast cancer mutation, later on in life. That these survivors of Hodgkin's disease would have that much of a risk of subsequent breast cancer. And so that led us to think about what are ways that we can tweak therapies to reduce exposure to radiation. So using different types of chemotherapy agents that may be just as effective as the radiation. And so a lot of work has gone into tweaking our regimens with the sort of being informed by what we've seen as far as late effects. So.
Okay. Yeah, absolutely. Well, thank you so much. We haven't gotten any questions, but we did get a comment. Awesome presentation, and I'm sure we have lots of folks who would echo that. Let me just mention a few more things in closing here. Whoops, it looked like we might have one more coming in. Nope. So we want to thank the North Carolina General Assembly for their generous support of UCRF, or the University Cancer Research Fund, that makes this possible. We want to thank the UNC Lineberger Comprehensive Cancer Center, and we want to thank the North Carolina Community Colleges for their partnership with this program. In particular, Renee Batts and Catherine Davis, who have been just outstanding partners. This concludes a series of 6 different lectures. Now, this lecture and all 5 of the others, this one will be online in a day or so. The others are already online, and you can, including closed captioning, and you can go to unccn.org and watch any of those outstanding lectures. We look on our site this summer. We hope to be able to announce more lectures for the community college system in the future. We'll be having conversations about that soon. If we would like to encourage encourage you to please do your evaluation. So you'll be receiving an evaluation link, and if you receive that link, please fill that out. We really rely on that information to get feedback about these and to make future lectures even better, if possible. So we look for those. I want to thank Dr. Tom Shea, Mary King, Alan Brown, Gene Sellers for all the hard work that they do to make this possible. Keep an eye on our website, unccn.org. There's information on how to contact us if you have questions about this series or other series, including our free series for continuing medical education, continuing nursing education, and the radiologic technologist education. So if you're a community college student who will be moving into a professional realm soon, we hope that you'll look to our site for lots of great education that you can receive to keep your certifications up to date. So that's there as well. Again, we're on the web, we're on Facebook, we're on Twitter, we're on YouTube. Find us there. Look forward to your comments and your questions and to seeing you again in the future. Thank you so much. And Dr. Smitherman, thank you. This has been great.
It's a pleasure. Thank you so much.